What's up? Time Talks Med here. Let's continue our complete cheat code for heart physiology. We're doing this in 4 segments. The first video was about the different types of cardiac muscle, the action potentials of pacemaker cells and contractile myocardium, and the general properties of cardiomyocytes. The second video was about the cardiac cycle, where we made an easy diagram illustrating what actually happens at each phase. The third video covered everything you need to know regarding the cardiac output, and this is the fourth video, where we will cover the regulation of the heartbeat, covering all the most important mechanisms that actually change the contractility and heart rate. Alright, awesome. Before we dive into the actual regulation, I just want to quickly remind you again about this equation, because it's so important to know that the quantity of blood pumped by the heart each minute, that is cardiac output, is influenced by the heart rate, that is changes in beats per minute, or the volume ejected per each stroke, that is stroke volume. Therefore, when we talk about the control of the cardiac activity, we always mention how it affects either the pacemaker activity or the myocardial contraction. Now, we are quite complex organisms, and a change in the function of one of these features almost always changes the other one. Some factors can favor one of these more than the other, like if the temperature changes, the heart rate increases, and if the myocardium is stretched, the contraction increases. But inevitably, all factors influence both of these to a certain degree. And there are a whole lot of factors that can influence the cardiac output. So I will give you the most important ways that the body can regulate our heartbeat, and we can divide them into myogenic regulation, neural regulation, and humoral regulation. There are many ways to classify this, but I find this method the easiest. I'm going to give you just enough info about each of these so you become an expert on how our body actually regulates the cardiac output. Let's now quickly go through the myogenic regulation first. Myogenic regulation is defined as the auto-regulated mechanisms involving the cardiomyocytes. So basically, the cardiomyocytes are the ones that affect the cardiac output. How? There are 2 ways. First one is the heterometric regulation. Now stay with me. Heterometric regulation means the heart's ability to adjust its contractility based on the length change of the cardiomyocytes. Here's the heart. We take out one contractile myocardium, which has, the actin, myosin, and tropomyosin. If the ventricles gets filled with blood, the ventricles are gonna stretch a little bit, leading to a slight length change of the cardiomyocytes. Imagine now that during the same cardiac cycle, the end diastolic volume is increased, so we get more blood filling up in the ventricles. What's gonna happen now? The cardiomyocytes are stretched even more, allowing for more cross-bridge formations. Now, when it ejects, the force of contraction is gonna be much higher, increasing the stroke volume, thereby increasing the cardiac output. This is called the Frank-Starling mechanism. So Frank-Starling's mechanism says, the greater the heart muscle is stretched during filling, the greater is the force of contraction and the greater the volume of blood pumped into the aorta. This is because the actin and myosin filaments are brought to a more nearly optimal degree of overlap to generate a strong force. So the force of contraction increases based on the position of actin and myosin to each other during the stretch. And this is just up to a certain degree. If the end diastolic volume is too much stretch can lead to less actin and myosin being able to meet. So Frank-Starling's mechanism is up to a certain degree. Now, what if we reduce the end diastolic volume? What happens to the contractile myocardium now? It's stretched just a little bit, so the force of contraction is also not so strong. So, a preload decrease leads to a decrease in stroke volume, causing lower cardiac output. Higher preload, higher stroke volume, higher cardiac output. This is the heterometric regulation based on Frank-Starling's mechanism. The other type of myogenic regulation is the homeometric regulation, which means the heart's ability to adjust its contractility based on other factors than the length change of cardiomyocytes. One way to do this is through the different ways calcium can be handled within the cell, and it can be explained using the Bowditch effect or the staircase effect. Bowditch effect says as the heart rate increases, the force of each contraction also increases up to a certain point. And this is due to the way the cells handle calcium. Let's see how. Just to give you a quick recap on how the contractile myocardium is depolarized, if you remember, you first get a neural stimulus from the previous cell. It positively charges the cell membrane, activates voltage-gated sodium channels at the threshold potential. Once the cell reaches about plus 40 millivolts, it will activate potassium channels, pumping potassium ions out. That positive charge will still continue along the cell membrane, activating L-type calcium channels. I'm just running through here since we already went through the depolarization steps in detail in the first video about the cardiomyocytes. So calcium comes in, triggering ryanodine receptors to open, which give off stored calcium within the sarcoplasmic reticulum. This calcium will now sit on troponin C, which eventually leads to tropomyosin leaving the binding site for the myosin on the actin, leading to the contraction of muscle. To relax the muscle, calcium goes into the sarcoplasmic reticulum through the calcium ATP pump. It can be pushed out of the cell as well through the calcium ATP pump, or we can exchange sodium with calcium, facilitated by the sodium-potassium pump, by pumping sodium out so more sodium can be pushed in exchange for calcium. And we got a lot of these sodium-calcium exchangers. Now, in a situation where we have a high heart rate, maybe due to the sympathetic stimulation, for example, the increase in heart rate is going to fire lots of neural stimuli and is going to cause the voltage-gated sodium channels to work more, in higher frequency, filling up the cell with sodium. Because we have a high amount of sodium within the cell, the sodium-calcium exchanger won't be as active anymore, because what's the point of exchanging calcium with sodium when you already have a lot of sodium inside the cell? So now, when the cardiac muscle needs to relax, it needs to put the calcium somewhere, so more calcium is pushed into the sarcoplasmic reticulum. Now, during the next contraction, more calcium is pushed into the cell from the sarcoplasmic reticulum, which leads to a stronger contraction. So, if you look here, because the cardiomyocytes puts more calcium within the sarcoplasmic reticulum with increase in heart rate, the contraction becomes stronger, but then eventually reaches a maximum contraction force. This increase in contraction with every beat is called staircase effect. So that was the myogenic autoregulation of the heart pumping. Now, what about the neural regulation? The neural regulation means the autoregulation concerning the nervous system, and it's divided into the extracardiac regulation and intracardiac regulation. Extracardiac regulation involves sympathetic and parasympathetic involvement. I can't express how important this is to know the mechanism of how the system can regulate the heart. Let's look into the sympathetic nervous system first. The sympathetic nervous system is our fight or flight response. So you want to increase the heart rate, increase contractility, and increase the cardiac output. Now, the sympathetic nerves that innervate the heart primarily originate from the upper thoracic segments of the spinal cord, approximately T1 to T5. These preganglionic fibers exit the spinal cord to reach the paravertebral ganglia. The paravertebral ganglia will now give off postganglionic sympathetic fibers towards the heart, specifically targeting the nodal cells and the contractile cardiomyocytes, releasing primarily norepinephrine, but also a little bit of epi as well. Most of the epinephrine comes from the adrenal medulla. Alright, let's zoom into one pacemaker cell and see what happens. We already went through this in a previous video, but remember, the pacemaker cells has funny sodium channels leaking sodium into the cell all the time, depolarizing it. As it gets more and more depolarized, T-type calcium channels starts opening, letting calcium into the cell. Once it hits threshold potential, L-type calcium channel starts opening up, giving us a massive influx of calcium. Once it's done depolarizing, the cell now repolarizing by opening potassium channels, letting potassium out, getting it back to its resting membrane potential. On the cell wall of pacemaker cells, we have beta-1 adrenergic receptors, which the epinephrine and norepinephrine binds to. These are G protein coupled receptors which activate when epi and norepi binds. Activated G stimulatory protein will activate adenylyl cyclase, which increases cyclic AMP production. to then activate protein kinase. And what protein kinase is going to do now is that it's going to phosphorylate and activate ion channels, specifically the L-type calcium channels, leading to more calcium into the cell, as well as phosphorylating the funny sodium channels, leading to more sodium into the cell. What happens now is that we get an accelerated depolarization during the pacemaker potential, increasing the heart rate. So we get a positive chronotropic action. So what about the contractile myocardium? Again, sodium comes in, depolarizing the cell, potassium channels open, potassium goes out, while the sodium channel close, L-type calcium channels open, leading to calcium influx, giving us the plateau phase. On the sarcoplasmic reticulum, we got ryanodine receptors, which open in a response to calcium influx from the dihydropyridine receptors. Calcium will flow from the sarcoplasmic reticulum into the cell, increasing the intracellular calcium levels. Now, calcium will bind to the troponin C, which eventually leads to contraction. And when the cell repolarizes, it gets rid of the intracellular calcium using calcium ATP pumps located in the sarcoplasmic reticulum and also in the cell membrane. Now, the contractile myocardium also has beta-1 adrenergic receptors, which follow the same pathway once the epi and norepi binds. G protein gets activated, which will activate adenylyl cyclase, which increases cyclic AMP production to then activate protein kinase. What protein kinase is going to do now is that it's going to phosphorylate the L-type calcium channels to enhance calcium influx during the plateau phase. What it's also going to do is that it's going to phosphorylate phospholamban and relieve its inhibitory effect on SERCA, the sarcoplasmic reticulum calcium ATPase, enhancing the calcium reuptake into the sarcoplasmic reticulum. Remember, phospholamban acts as an inhibitory for SERCA pump under normal conditions, reducing its affinity for calcium. This means while the SERCA pump is still active, its efficacy is lower compared to when phospholamban is phosphorylated. So what happens now? Now we have so much calcium within the sarcoplasmic reticulum for the next depolarization. So we release out more calcium into the cytoplasm. More calcium means more interactions with troponin, which moves the tropomyosin. If you move the tropomyosin, you're going to have more actin and myosin interactions. So you're going to have a significantly more cross-bridge formations. If you have more cross-bridge formations, you have more power strokes, more sliding of the myofilaments, and that's going to increase the actual contraction. So we will have an increased inotropic action. And since it enhances the reuptake of calcium by phosphorylating phospholamban, we will also have an increased rate of myocardial relaxation as well, so increased lusitropic action. All that will essentially increase the stroke volume and increase the cardiac output. So the overall effect of the sympathetic nervous system is a positive chronotropic action because you increase the heart rate in the pacemaker cells. We will get a positive dromotropic action, meaning the conduction velocity. So sympathetic stimulation increases the conduction velocity of the electrical impulses through its action on the AV node. So phosphorylation of the L-type calcium channels in the AV node speeds up the depolarization phase, reducing the delay of impulse transmission from the atria to the ventricles. We also get a positive bathmotropic action, because if you increase the calcium and sodium currents within the pacemaker and contractile cells, you increase their excitability as well. And as we just said, we get a stronger contraction and enhanced relaxation speed through the sarcoplasmic reticulum calcium channels. How does the parasympathetic nervous system act on the cells then? The parasympathetic nervous system is our rest and digest system. Now, the sympathetic comes from the thoracic spinal segments. The parasympathetic innervation of the heart primarily comes from the vagus nerve, the 10th cranial nerve, and it originates in the medulla oblongata. And then it goes to innervate the heart through the right and the left vagus nerves, and it's going to give off acetylcholine. Acetylcholine will bind to muscarinic receptors on the SA node, activating G inhibitory proteins. G inhibitory proteins will inhibit adenylyl cyclase activity, leading to a decrease in cyclic AMP levels, opposing the action of the sympathetic activity. What it's also going to do is that it's going to activate the potassium channels, leading to a higher efflux of potassium ions, hyperpolarizing the cell membrane. What's that going to do? It's going to decrease the heart rate, negative chronotropic action, and also decrease conduction velocity, negative dromotropic action, because the muscarinic receptors, specifically M2 receptors, are densely populated in the sinoatrial node and the atrioventricular node, and this explains the significant effect of the heart rate and conduction velocity. The density of the M2 receptors in the atrial contractile myocardium, and especially ventricular myocytes, are relatively lower. That's why the direct effect of acetylcholine on the contractile strength of the heart muscle is less pronounced, but it do cause a light decrease in inotropy as well. So that was the overall effect of these two systems. Another system that's really important to mention here is the medullary control of the cardiovascular system. One of the major sources of excitatory input to the sympathetic nerves is a group of neurons located near the outer surface of the medulla, in the rostral ventrolateral medulla. These neurons have axons that descend in the lateral column of the spinal cord to the thoracolumbar area, giving off sympathetic innervation to the paravertebral ganglia, to then give off postganglionic innervation to the heart, again increasing the heart rate and the cardiac output, like we just saw. It's also going to cause vasoconstriction and also stimulate the adrenal medulla in releasing epinephrine. So what is it that stimulates these nerves? We got chemoreceptors in the carotid and aortic bodies. We got baroreceptors, which are stretch receptors in the walls of the heart and the blood vessels. There are also descending tracts from the limbic cortex as well, that is responsible for rise in blood pressure and tachycardia produced by emotions, such as in stress or anger or sexual excitement. Pain usually causes a rise in blood pressure also by sending signals to this area as well. Now, the medulla is also a major site of origin for excitatory input to the cardiac vagal motor neurons in the nucleus ambiguus and the dorsal motor nucleus of the vagus, which give off parasympathetic innervation. Things like inflation of the lungs causes vasodilation and decrease in blood pressure. This response is mediated via the vagal afferents from the lungs that inhibit RVLM and sympathetic nerve activities. I'm not going to confuse you too much with this. I just want to show you how the baroreceptors and the chemoreceptors affect these systems and essentially the cardiac output of the heart. Now, within our body, we have something called peripheral chemoreceptors. These are receptors that are located within the aortic body and the carotid bodies, and they have a very high rate of blood flow. These receptors are very sensitive to changes in partial pressure of oxygen, carbon dioxide, and pH levels, and they are activated if there's a reduction in partial pressure of oxygen, increase in partial pressure of CO2, or a decrease in pH. So if you're on a mountain or a place with a high altitude where the atmospheric oxygen levels are lower, peripheral chemoreceptors will detect that decrease in arterial oxygen. Another example is that if there's a condition such as chronic obstructive pulmonary disease or pneumonia, that can lead to hypoxemia, stimulating peripheral chemoreceptors as well. Or if there's a respiratory failure, peripheral chemoreceptors respond to the increase in arterial CO2 levels. Or even conditions such as diabetic ketoacidosis or severe diarrhea can cause an increase in blood acidity as well. Now, afferent nerve fibers will now travel from the peripheral chemoreceptors via the glossopharyngeal nerve from the carotid bodies and via the vagus nerve from the aortic bodies, and they will go to nucleus tractus solitarius. Nucleus tractus solitarius integrates incoming sensory information from the peripheral chemoreceptors, and then it tells that information to the rostral ventrolateral medulla, which is also called the cardioaccelerator area and the vasomotor area, to initiate a sympathetic activity, primarily increasing the heart rate and cardiac output, causing vasoconstriction and stimulating the adrenal medulla. All this is to ensure coordinated reflex response to optimize the oxygen delivery, carbon dioxide removal, and acid-base balance in the body. Now, we do also have something called baroreceptors. These are stretch receptors that react to stretch of the arterial walls located in the same area approximately as the peripheral chemoreceptors. Specifically, they're located in the walls of the heart, and in the carotid sinus and the aortic arch. They respond to stretch caused by a sudden change in the blood pressure. So when there's a sudden increase in blood pressure, it will increase the baroreceptor activity. And if there's a decrease in blood pressure, it will reduce the baroreceptor activity. Make sense? All right. Now, when they're activated, signals will pass on via the glossopharyngeal and the vagus nerve to the nucleus of the tractus solitarius. Nucleus of the tractus solitarius will do two things. It will go to the neurons of the caudal ventrolateral medulla, releasing glutamate. The caudal ventrolateral medulla will go to the cardioaccelerator and the vasomotor area and release the inhibitory neurotransmitter GABA. This leads to a reduction in sympathetic activity. Nucleus tractus solitarius is also going to give off glutamate and activate the cardio-inhibitory areas and activate the parasympathetic activity towards the heart, reducing the cardiac output and blood pressure. So how this works is that you have a set point or desired range of blood pressure, and if the blood pressure deviates from the set point, meaning it gets either too high or too low, the nucleus tractus solitarius initiate appropriate reflex response to restore blood pressure to normal levels. So that is mainly the extracardiac regulation. We do have some neural intracardiac regulation as well. I'm not going to go into too much detail into this, but we have something called intramural ganglia embedded within the myocardial itself, consisting of a cluster of nerve cell bodies, and they're all interconnected via nerve fibers to form a network that spans throughout the heart. They are classified as intrinsic cardiac nervous system because they regulate the cardiac functioning independent of the direct CNS control. So what they do is that they receive signals from the sympathetic and the parasympathetic nervous system, and they integrate and modulate the response to ensure coordinated cardiac functioning. And often, if something happens to these ganglia, it can contribute to developing arrhythmias. In addition to that, we also have low pressure baroreceptors here as well, sensing stretch within the walls of the heart, initiating the same response as the baroreceptor response. So I'm just going to keep it at that for the intracardiac regulation. So that was the neural autoregulation. Then we got humoral regulation. Humoral regulation are hormones within the blood that influence the heart rate, contractility, and overall cardiac output. One of the main ones are the epinephrine released by the adrenal medulla as the sympathetic control, activating the beta-1 adrenergic receptors. Another way is through the Renin-Angiotensin-Aldosterone system. This is one of the most important systems you need to know by heart. This system is so important in both physiology and pathology. So what this system is essentially is that the liver secretes angiotensinogen. If there is low blood pressure, that will decrease the perfusion to the juxtaglomerular cells of the kidneys, causing it to secrete renin. Renin acts on the angiotensinogen, converting it into angiotensin 1. Angiotensin 1 is converted to angiotensin 2 primarily by the angiotensin converting enzyme, which is located predominantly in the lungs. Angiotensin 2 is so important in our body. It can directly act on the myocardial cells, increasing its contractility by enhancing the calcium influx through the L-type calcium channels. It can directly cause vasoconstriction, increasing the systemic vascular resistance, which increases afterload. Because remember, the initial response was low blood pressure. Angiotensin 2 also stimulates the release of ADH, antidiuretic hormone, promoting water reabsorption in the kidneys, contributing to an increased blood volume and thereby increase in preload. But what it also does is that it can go to the adrenal cortex and stimulate the release of aldosterone. Aldosterone will go to the nephrons and cause an increased sodium reabsorption and potassium secretion. Remember, wherever sodium goes, water will follow. So that will essentially increase the blood pressure, which will increase the preload and increase cardiac output. Aldosterone can also act directly on the heart by binding to mineralocorticoid receptors, essentially enhancing the force of cardiac contraction. And it also does something called cardiac remodeling. Same with angiotensin 2, meaning a chronic or prolonged expression of those hormones can lead to cardiac hypertrophy, which is an adaptive response initially, but can progress to heart failure in the long term. And it can also promote things like cardiac fibrosis. That's why sometimes the aim to treat heart failure is to block aldosterone actions and reduce the blood pressure. Alright, what else? Thyroid hormones. Primarily T3 is the active one. Thyroid hormones binds to thyroid hormone receptors, which are present in the cardiac myocytes. What happens initially is that it's going to influence the gene expression, metabolism, and ion channel activity to increase the heart rate and enhance contractility. Not to go into too much detail, but that's why if there's a hyperthyroidism, that can lead to tachycardia and palpitations and increased cardiac output, and sometimes even arrhythmias. While in patients with hypothyroidism, can have things like bradycardia and decreased cardiac output, or even in severe cases, symptoms of heart failure. Alright, another hormone secreted by the adrenal cortex are glucocorticosteroids. What this hormone does is that it's going to cause an increase in myocardial contractility and heart rate, and it does that by enhancing the adrenergic receptor sensitivity and promoting the pumping of calcium into the sarcoplasmic reticulum. And they can also increase the responsiveness to catecholamines in the blood vessels. All that apart from the fact that glucocorticoids also enhances glucose release into the blood, so increasing the availability of glucose and thereby increasing the availability of ATP. Alright, another humoral regulation we have are through the natriuretic hormones, specifically the atrial natriuretic peptide and the D-type natriuretic peptide. If there's an increased pressure within the atria and the ventricles, the myocytes will get stretched and release AMP and BMP. They will then promote dilation of the arteries, reducing blood volume by removing sodium and water through the kidneys, and thereby decreasing the cardiac preload and afterload. By doing that, we get a reduced myocardial workload and lower blood pressure. If you get a patient with heart failure and you analyze their blood, you might sometimes see that they have an elevated levels of BMP and AMP. So they can be used as biomarkers for helping diagnosis of heart failure as well. Now, you already know how important calcium and potassium are to the depolarization and repolarization of both the contractile myocardium and the pacemaker cells, as well as how important they are for contractility. But what happens if we have hypercalcemia? If a patient has high calcium levels in their blood, you can expect the patient to have an increased contractility because the elevated calcium levels can enhance myocardial contractility by increasing calcium availability for each contraction. Now, we haven't gone through the ECG yet, but on the ECG, you have PQRST, where the QT interval shows the time from the beginning of the depolarization to the end of repolarization of the ventricles. In hypercalcemia, you will get a shortened QT interval because the repolarization phase becomes accelerated. And they're also at a higher risk of arrhythmias. So any changes in any ions that the cell utilizes for depolarization and repolarization are at risk of arrhythmias, especially with potassium. Now, in low calcium levels, you will see the exact opposite, so decrease in contractility and prolonged QT intervals. Sodium, remember, it maintains the resting membrane potentials of contractile myocardium because potassium ions tend to leak out of the cell due to their concentration gradient, making the inside of the cell more negative. Potassium also helps with the repolarization phase of the cardiomyocytes. So if someone has hyperkalemia, the resting membrane potential now becomes less negative because less ions are able to leak out, making the cardiac cells less negative and closer to the threshold for depolarization. And this is bad, really bad. If the contractile myocardium are close to the depolarization, they're more excitable and more prone to arrhythmias. High potassium values also slows the conduction and can lead to bradycardia and conduction block. So if you do an ECG, one of the earliest signs of hyperkalemia are peak T-wave because the increased potassium causes the process of repolarization faster and more pronounced, resulting in the characteristic peak appearance of the T waves on the ECG. And since the conduction speed is slower, you will often see a wider QRS complexes as well. If the patient has low potassium, the contractile myocardium's resting membrane potential will be more negative, increasing the distance from the threshold for depolarization, making it harder for the cell to contract. So hypokalemia also causes prolonged repolarization, which can increase the risk of early after depolarization. Now, on an ECG, you will see the exact opposite of hyperkalemia. So you will see a flattened T wave because the repolarization phase is slow, and you can see prolonged QT intervals as well because of the prolonged repolarization. Now, I don't want to scare you with the next slide, but I did make a quick summary slide. It doesn't contain all the information. I just tried to compress everything in case you want to pause the video and take some notes. There's always something you can add to this list. So that was everything I had for the regulation of the heartbeat. So we covered in this video the myogenic, neural, and humoral regulation of the heart. Thank you all for watching. If you found this information helpful and want a little extra practice on the regulation of the heartbeats, I've created a quick follow-up video with quizzes and questions. These resources are available exclusively for channel members, and I've kept the membership fee as low as possible to support the channel's growth. Your support means so much to me. Consider becoming a channel member to access these additional resources and help me continue making more educational content like this. Just click the join button below to get started. Thank you again for watching, and I hope that was helpful. See you in the next video. Peace.